روان کردیم نی؟
بله.
اینه چرا ما انگلیسی میگم بازم هر وقت سوال میکنین یا صدایتان رو بالا کنین یا ویدیوتان رو روشن کنین که من دستتان رو ببینم با سرش کپ میزنیم. خب care of normal newborn من بسیار ساده و آسان با امرایتان گپ میزنم. ببین کنین suction of the mouth first and nose second after the delivery of the anterior shoulder. Why mouth first and nose second? We have talked about this before. Because if you suck the nose first, it will stimulate the nasopharyngeal reflex and the baby would gasp. Anything is in the mouth and the back of the pharynx, it's going to go to his lungs. So what you need to do, you need to clear up the nasopharyngeal area in the back, then you suck the nose. And for you not to forgive, because according to alphabet, M comes before N. The mouth is first and nose is second, and we'll never forget. So we won't do it backward. Hold the infant firm against your body and further suction the mouth and the nose. Against the body, چی مانومتر؟ اینه ما براتون اینجا تصویر مرا میبینید نه؟
بله.
من اینجا استادمشون براتون میدم. اینی فرض میکنیم که باشن اینجا یک چی دارم در طرف طفل از دستم نمیلخشه. ما بسیار طفلا را دیدیم که در سطح لفت دیدن. فقط اینی دو دستتان واس کنید دو کلکتان اینه تا در پشت گردنش کنید. میبینید گردنشه؟ میبینید؟
بله بله
بله استاد.
میبینید اردو انگشتتان شانه‌اش سپورت میکنه. شانه‌اش سپورت میکنید به وضعیت ترندلنبر در بغلتان محکم میگیرید. اینا چی میکنه؟ اول خود این از پشتم نمیفته جایی. بسیار محکم شد درجه که در انگشتایتان بپوشونید. دومیسته که دست دیگه تان فارغ است. که را پاک کنین، خشک کنین و سکشن کنین و تنبیه کنینش. بهترین چیزی که براتون میکنه که یک دستتان او که از پایش میگیرن و بازی رو در پایچن اونا با کلی متروک کساری و کار کس نمیکنه. Immediately dry the infant. Head and body which will stimulate his میکنه که همیره تنبیه میکنه و هم فوق‌العاده oxygen consumption is going to go really down. If you're taking a shower and going standing under a fan, immediately you're going to shiver. That means that you need more oxygen. So if you are wet, you lose your heat very fast, and then your oxygen consumption is increased. But drying the baby, the head first, because the most heat is lost by baby's head. Dr. Kazumi, I need your help if I'm wrong. Please interrupt. So the most heat is lost from the baby's head. And then you do two things. You dry it first and very vigorously, and that stimulates the baby too. In the meantime, you suck the baby. So that's going to bring 95% of the babies with good Apgar for you. So that's very important. Immediately dry the baby. Clamp and tie the cord about 1 to 2 inches from the skin. Okay? And then record Apgar score. We're going to talk about, the Apgar score, but we'll have a chart here for you. You may put the infant of mother abdomen and keep her warm. And here we have a warmer. This is a warmer right here. It's a radial heat from top. So your hands are open, the baby is not covered, and the temperature is kept at 37 degrees. So you can easily and freely work on the baby. And if you put that on the mother's stomach, then the radiant heat is there. The prospective randomized studies showed that after the baby is Apgar is good in 2, 3, 4 minutes, you know, once you hold the baby, you know how baby is good muscular tone and crying and so forth. Then the randomized trial has proven that if the babies are put on the mother's chest, they immediately suck their nipple. And they compared it with people who don't do that, and later on it goes to the mother. The people, that's called a mother binding. The infant that binds with the mother immediately, they were followed up to the 7th and 9th grade. And they found that from the neurobehavioral standpoint, they did it much better when comparing to the other group. So I think it is beneficial for the baby to be put on the mother's skin, not on the clothes. Skin, keep it warm, and let the baby, if it's possible, to suck. But you want to make sure that the baby is good condition. Okay? Encourage the mother to put the infant on her breast. Complete physical examination of the infant is necessary. You listen to the heart, you listen to the lung, you look at the eyes, and make sure that all the fingers are there, and look at the abdomen, make sure there's not a tumor anywhere, and so forth. So the complete physical exam. Treatment of the eyes, I'm sure you all do that because of the GC eye infection. Weight and length of the infant, and then identification of the infant. I don't remember to have you identify, but here is a bracelet that the mother name goes there. So the baby will not lose it, so you won't confuse one baby with the other. Normal infant can be circumcised immediately after birth. Don't worry. If you have Gomco clamp, now we in Shahada Hospital in Jawari, Dr. Kazemi is, you are circumcising after the delivery if the baby is good, right?
Yes.
Yes. So it's all right to circumcise them, particularly with Gomco. So newborn resuscitation. When infant becomes asphyxiated, either before or after birth, they demonstrate a well-defined sequences of events, pushed up, leading to primary or secondary apnea. This is a statement from American Academy of Pediatrics and American Heart Association. So first, primary and secondary. Initial oxygen deprivation results in transient period of rapid bleeding. First, rapid bleeding, because initially when the baby is transferred from the womb back to the open air, there's an initial deprivation, a reduction of oxygen. So rapid breathing, and that clears up the fluid from the baby's lung. If this deprivation persists, breathing ceases and fetus enters a primary apnea. You want to make sure that initially, so that stimulation and suction of the mouth and the nose and stimulation and drying, or 95% of the time prevents this, unless if the baby is in other kind of trouble or premature. So that deprivation is prevented by what we talked with the previous slide. Everybody understand what I'm saying?
Yes.
Great. Very, very good. Bradycardia and loss of muscle tone, that's the will follow. After the primary apnea, so bradycardia and muscle tone will follow. As soon as the baby is born, I'm sure you've done it hundreds and thousands of times. And when you hold it in your lap, you know how good the muscle tone is. That's immediately a good sign. And you just promote that by drawing and so forth. Simple stimulation and oxygen as the administration will reverse primary apnea. مثل که بیشتر گفتیم. If oxygen deprivation and asphyxia persist, fetals will develop secondary apnea due to any reason, either obstruction of airway, prematurity, infection, and we're going to talk about that in just a minute. This is associated with further decline in heart rate and loss of neuromuscular tone. Because when muscles become hypoxic, you know that lactic acid develops in the muscle, and that causes metabolic acidosis, and the muscle will not function. So it's a totally relaxation of the muscle. Infant in secondary apnea will not respond to stimulation and will not spontaneously resume respiratory effect. At the primary apnea is the opposite. With stimulation and oxygen, they will do a spontaneous breathing. But if once the secondary apnea, then the baby needs resuscitation. So if ventilation is not assisted, death will occur. این وقت باید برای مریض آدم ventilation کنه. Clinically, primary secondary apnea are indistinguishable. اگر از اول آدم نبینه تا آخر مابینش فرق شده نمیتونه. For this reason, resuscitation of the apneic infant must be started immediately. مجردی که ببینیم که apnea پیدا کرده باید فوراً resuscitation کنیم. You don't care if it's primary or secondary, because if it's primary, we'll respond to a little stimulation. If not, immediately you should resuscitate. The first breath of air, that's very important. Initiation of air breathing. Transient tachypnea, as we talked about it, of the newborn, delay in the removal of fluid from alveoli. So tachypnea and then breathing starts, this alveoli will clear up the fluid because you know infants are constantly aspirating amniotic fluid. Pulmonary artery pressure falls as soon as the oxygen saturation leaves, and ductus arteriosus closes. So the infant circulation will convert to adult extrauterine circulation. Alveolar surface tension, you know, this is very important. We have talked so many times about this, about surfactant, which is a phospholipid. And if baby is mature and there's enough surfactant there, so what happens? The tension, surface tension of the alveoli. When it's expiration, the alveoli goes back. Inspiration, it goes back. If there is enough surfactant that is produced by type 2 alveolar cell, then the surface tension will not be so strong and it'll go back to the same diameter, back to the same. If it's not surfactant, then every time that the inspiration diameter is going to go small, 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 and then lung will collapse. And that's what's called respiratory distress syndrome, infant respiratory distress syndrome. And in adults, it's the same thing. The stimuli to breathe air, physical stimulation, compression of the thorax, and CO2 accumulation also stimulates the breathing center in the brain and babies start breathing. Fetal oxygen requirement. This is very important. And this definitely will be in your future questions.
Okay.
So the baby lives in a 65 OSAT, oxygen saturation, with pH of 725, which is perfectly normal. You and I can't live below 96. And it really, we can live, but it's going to be hypoxic. But if it goes below 94 and 90, then it's really critical. So why fetus survives here? Fetal hemoglobin, which has high affinity with oxygen. Fetus has polycythemia, so to compensate for that low oxygen. Amniotic fluid osmolality is one of the most important factors, which is a specific gravity. The fetal tissue in the amniotic fluid osmolality is the same. So the baby floats. It's like if you put a piece of wood, in the water, the osmolality of the wood in the water is the same, so the wood will float. Once you float and you become weightless, the oxygen consumption is dropped by 50%. People who scuba dive under the water are people who go to space, that they float. Their oxygen consumption is about 5 to 10% of you and I. So because you lose the muscle, there's a resting tone and it's activity tone. You don't need any more oxygen for your muscle resting tone because you're floating. Your muscle resting tone is supposed to keep you straight. If you didn't have muscle tone, we would be like a jelly. So that's very important to understand. So oxygen requirement gradually increases and during the term. When the term approaches, then osmolality gradually increases and the baby sink ترسب میکنه the حوصله مادر که اینی خودش یکی از علل انگیج شدن است. و زمون خاطر است که در وقتی که طفل به 41 or 42 تراویک میرسه, since the baby needs a lot more oxygen, then we talked about it in the post-datism, that we need to deliver that baby if it doesn't receive enough oxygen. So that's because of the osmolality. Before we had surfactant, we drew amniotic fluid and checked the osmolality. If the osmolality approached 0, then we thought that this baby was 49 or over. It was pretty good relation. So that was how to check the fetal maturity. The role of resuscitation. 1, 2, 3, 4. What do we do? This should be printed and put in the labor and delivery room. Rapidly recognize the infant cardiopulmonary status. So, of course, you have an assistant. If you try to resuscitate, somebody listen to the heart, and the best thing to do with each beat, it moves his finger. So you'll know if the finger is like this or the finger is like this. So you'll adjust your oxygen or intubation, whatever, because the lower the oxygen, the bradycardia is more when we saw. Suction the mouth and nose and trachea can result in significant vagal stimulation. You have to be careful. And reflex, slowing the heart rate. When you stimulate, be careful if you stimulate the larynx, sometimes baby goes to an apnea. Skilled personnel must be immediately available. And that's the job of the neonatologist or pediatrician. If you expect problem, you need to get some more help. A suitably heated, well-lighted, large working area, as you saw in the previous slide. So that's very important for you to be able to work freely around the baby. Equipment should be available right there. Positive pressure oxygen delivery system, face mask, laryngoscope, endotracheal tube, and suction. That should be available immediately after delivery. Drugs, syringes, needles, umbilical catheter, IV tubing, and solutions, naloxone or Narcan, particularly if you give people narcotics, sodium bicarbonate, and epinephrine. One thing you have to remember, you can keep, I don't know if you talked about analgesia and anesthesia during labor. It's very safe for you to use narcotics. Morphine or Demerol or Susigan. But there's one thing you need to, if the baby looks good and everything, make sure that you inject your medication rapidly 12 seconds before the next contraction. So you put your hand on the fetus, on the fundus, and as soon as you feel that the contraction is coming, you inject. Why? Because the circulation time between the arm and the uterine artery is 13 seconds. So by the time that blood goes into the uterine artery, you know that during contraction, there is no circulation between mother and the infant. So that drug goes into the central nervous system and just attached to the receptors. By the next circulation that it comes, that the drug is so diluted that it doesn't have no bearing effect on the baby. And you see that when you do a C-section under general anesthesia. Mother is totally asleep and baby comes out crying and breathing. So it's very important to give your medication, keep the patients comfortable, but give it like 13 seconds before the contraction. And that's very important. And adequate record keeping. The record keeping is very, very important. Management of delivery. Immediate care, evaluation of the infant, health status of the mother is very important. You have to know if mother diabetic, mother had, GBS positive or whatever. Prenatal complication, labor complication, gestational age, which is extremely important. You deal with at 34 weeks, so much different than 28 weeks and the 34 weeks and 37 weeks. So that's important to know that. Duration of labor, duration of ruptured membrane. We talked about this in prophylactic for GBS on the 5 risk group. Administered medication, what medication mother received. If mother received too much narcotic, as we saw before, so Narcan should be available to reverse because it's an antidote of narcotic. Anesthesia, what kind of anesthesia mother had, and difficulty with delivery. Whether had a posterior position, a lot of episiotomy, forceps, operative vaginal delivery, whatever. These are all should be taken into consideration for resuscitation. Okay. Management. Lack of effective respiration. Causes include effective respiration is not there. So these are the causes. Fetal hypoxemia and acidosis. Drug administration to the mother. Or mother is drug addict. He comes in with a lot of cocaine or a lot of morphine or tariok in her circulation. Fetal immaturity, we talked about it. Upper airway obstruction. We have to look at that and suction. That's why we need suction. People who have thick meconium amniotic fluid, we recommend we see how you do this. You will recommend the suction of the trachea so the thick meconium will not be aspirated. Because thick meconia, as all pediatricians know, it's very difficult to get absorbed through the alveoli and it causes meconium pneumonitis. It's important to clear up the airway. Pneumothorax. If you don't have ambu bag and you want to use your mouth to breathe into the baby's mouth, make sure that you don't use your diaphragm because your diaphragm will immediately cause pneumothorax. So you use your cheek, and this is 5 millimeters of water. That's all you need to open up the lung. So you'd go like this, not from your diaphragm. That's very important. I have seen quite a few babies who develop pneumothorax because they use so much pressure. This ambu bag that you see here, it's designed not to deliver more than 5 centimeters of water. Meconium aspiration, we talked about it. Other lung abnormality, maybe he has a lung disease. Aspiration of amniotic fluid. CNS development abnormality and septicemia. if this patient was delivered from a chorioamnionitis, and you already know that, mother's fever, tachycardia, we talked about chorioamnionitis and its symptoms. So this all has to be taken into consideration. And of course, Apgar score, you know, heart rate, absent, below 100 and over 102, and you just give a 1 minute, but the 5 minute should be given, and 5 minute Apgar is more important than 1 minute Apgar. The Virginia Apgar was a lady in the 50s and 60s, discovered this, and it's under his name. Umbilical cord, this is not available in Afghanistan. Look here, if the pH is 7 or less, 9 infant seizure, 7 infant died, intensive care 17 baby, intubation 32 babies, and 1 minute Apgar was 23, was less than 3, and 5 minute Apgar, 9 of them was less than 3. Look here, if you have somebody who has the pH was 710 to 714, look how less morbidity is in terms of mortality, morbidity, asphyxia, and so forth. So these are something that also is going to be in your test question. Let's define what's hypoxemia. Hypoxemia is decreased oxygen content into the blood. Hypoxia is decreased oxygen content into tissue. Acidemia is increased hydrogen ion concentration into blood. And that's what causes metabolic acidosis. Acidosis, increase of hydrogen ion and concentration into tissue. Asphyxia, hypoxia with metabolic acidosis is asphyxia, which is the end result of deprivation from oxygen. Clinical diagnosis. Deprivation of oxygen causes metabolic acidosis, and we talked about this, will lead to metabolic acidosis, anaerobic metabolism that we talked about it, umbilical artery. So we talked about all that. Apgar score is immediate tool for diagnosis. The best diagnosis for hypoxia, acidosis, whatever, is Apgar score. Umbilical artery blood gas measurement. In the United States, it's standard as soon as the baby is delivered and cord is cut, you get a cord blood sample and send it for blood gases. It has to be on record for every baby. Umbilical artery blood, then persistent Apgar score of 0 to 3 for more than 5 minutes. That's signs of asphyxia, neurological sequences, seizure, coma, or hypotonia. This is all signs of asphyxia. And also multi-organ system dysfunction. The kidney does not work anymore, the lung collapses, and the heart goes to bradycardia. So these are all the diagnosis of asphyxia. This is another one with the blood pH, and it tells you that if it's 7.2, you see that the prognosis is much better. It just tells you that the pH is very important. Active resuscitation, when you do, there's what happens. Rapid breathing, we talked about this. In primary apnea, so you do a irregular gasping. If you don't just deliver enough oxygen and stimulate the patient and do a mask resuscitation, then the secondary apnea is going to develop. And with a secondary apnea, heart rate goes down and blood pressure goes down. And that's where the baby needs vigorous resuscitation with intubation and heart massage and medication and all that. Because acidosis develops very rapidly. And they normally, as soon as they see this, they put in umbilical catheter into the umbilical vein, and they give him some bicarbonate. I'm not an expert in that, so Dr. Tadini knows more about this than I do. After delivery, as well as defined sequences of vent loading, which we talked about this, primary apnea, secondary apnea, rapid recognition of the newborn condition, and a skilled personnel is very needed. This is all your equipment. It should be in the wall, ready for you to go get it, and it all should be sterile and ready. So suitable, well-heated, large working area, equipments, drug needle syringes, intravenous solution, epinephrine, or naloxone. That's very important. It should be there. And that just shows the intubation and what you need to do. I'm sure from time to time you have a stillbirth, which is unfortunate. But then we have to practice on a stillbirth how to intubate the baby. It's very important. This is the baby's nasopharyngeal area is very, very fine and delicate. This is a metal instrument. And you can injure that very easily and cause so much edema that the upper respiratory will close. So you have to be experienced with this, gentle with this, and how to do it. And I'll show you a technique here. Unfortunately, or not unfortunately, fortunately, we didn't have any stillbirth baby, so we could practice on it. But I can assure you, if you have a stillbirth baby, and what I'm going to show you next, you're going to be able to intubate very easily with your finger, with a lot less trauma, and very effectively. Okay. Prevent heat loss, open the airway, evaluate the infant, respiratory effect, heart rate. This is all color. So Apgar is going to help you what to do next. Chest compression, and tracheal intubation, and blind intubation, and chemical resuscitation with bicarbonate or with naloxone or Narcan or epinephrine, whatever is necessary. So that's the ambu bag for the infant, which only there's an oxygen attached here, so it only allows 50 millimeter water pressure. So it has a safety valve here. If you push this, only cause it. So this is a little algorithm that I prepared for you. Intrapartum suction of the mouth and pharynx and nose, okay? For people who have meconium. As soon as you have meconium, particularly if it's thick meconium, you need to follow this algorithm. Okay, nose. 10 meconium, 10 mucus, infant active, observe, and resuscitate PRN if it's needed. So you're practically home free. See, 10 meconium is not that dangerous. Infant depressed, you go to the resuscitation. But as infant is active, you don't go. You don't need to do anything. Just observe and do it PRN. Thick meconium, suction trachea. And what you need to do as soon as you put your endotracheal tube, whether manually or by laryngoscope, you should have a suction ready. So as soon as you see the trachea, you put that suction in the trachea to get this meconium up. Suction trachea. Infant depressed, resuscitate. If infant not depressed and start become active, then you're home free. So that's a nice algorithm if you follow for people who have meconium. This is called delete trap. I don't know, I don't think you have it. So when you suck this with your mouth, better to suck with your mouth because you don't want to hook this into the wall section. That's so powerful that it's going to suck the tissue from the lung or from the trachea. So just by your mouth. So you don't have to get all the meconium in your mouth. And you have a pea soup for dinner. And I have done that.